We're so happy to welcome back Dr. Greg Babcock from Carl, interventional radiologist. Did you start your career as a radiologist and then move into interventional radiology?
Yes, I did.
Okay.
Right now, most of the interventionalists that are out there have either just been practicing for a really long time and they do procedures, or they've been through a fellowship. And that's generally where most of them have done it. You do a regular 5-year residency program with just diagnostic radiology, and if you like this portion of it, you subspecialize in interventional radiology. And after your fellowship, you take boards, which gives you the Certificate of Added Qualification, CAQs is what they call it, because it's easier. And then you go out and practice as an interventional radiologist.
Okay, now let's just explain real quick, what do radiologists do? I know they read images, but what kinds of things do radiologists do?
Well, radiologists are going to give you a diagnosis based on the imaging, or at least give the ordering physician a differential list of what it likely is, or what it, if it's not this, it's this.
Okay.
And they use ultrasound, magnetic resonant imaging or MRI, they use CAT scans, they use nuclear medicine, and they do PET scans.
Okay. How long has interventional radiology been around?
It's been around for a while.
Okay.
It's been around for a while. It's been around ever since some of the giants, when they first came out with it, are the ones that developed the coronary artery stenting and being able to get in there doing angioplasty of vessels. So it's been around a pretty long time.
But from what I understand, a lot of the procedures you do have sort of, in some cases, taken the place of traditional surgery. You know,
absolutely.
Cutting, and so for patients like us, that means less recovery time and that sort of stuff.
Yes, because another way of looking at it is either image-guided or minimally invasive surgery. And these are basically small procedures through small little incisions.
That's what I was going to ask when you say image-guided. Are you using cameras, you know, that are fed through arteries, or?
It depends on the procedure.
Okay.
For the most part, I'd say the bulk of our procedures are done with fluoroscopy, which is real-time video x-rays. And what we do is we have people laying on a table much like this one, and then we have an image intensifier and an x-ray source. And they kind of sandwiches the patient, and we can move it around, and we just focus in, and we keep it as narrow and as small as we can to see exactly what we're doing. But sometimes we use ultrasound, and we use that to guide our needles and some of our other things that we're doing. And occasionally we'll even do things under CT or CAT scans.
Okay. And it seems like a lot of these procedures are done not under the traditional heavy anesthesia.
That's true. I'd say some of our easiest procedures, you almost don't need anything more than just local lidocaine or something like that to take care of the access site. But for the more onerous type of things, or the ones that we know we're going to have the patient, even if they're not difficult procedures, if the patient's going to be on the table for a while, we do use a combination of medications to kind of put them in a twilight where comfortable and relaxed, but not purposely asleep. Occasionally our patients will go to sleep. That's okay. But we don't purposely put them to sleep.
Which that I would imagine, I mean, if you have to have, is it, you know, the real anesthesia, that you have to have that, but not having to go way under is better if you don't have to. It's
easier for recovery. It's definitely cheaper as far as doing the exam, because that's a whole another added cost. And there's also a recovery time for doing that. Some of our procedures do require either full anesthesia or what we call MAC, monitored anesthesia. And we just put them a little bit heavier, so maybe they will purposely go to sleep, but we're monitoring them much closely.
Well, one of the things that you do is you take care of people who have a compression fracture in their back.
Yes.
Let's talk about what is, from what I understand, compression fractures only take place in the spine. Can you explain what a compression fracture is?
Well, sure. In the spine, if you think about it, it's a long column that is basically providing two main functions. One is support of your body. And that's where the vertebral bodies, which look like little round bricks or little round sandwiches that are flat on the top, and they just stack. And it's that stack that gives the body the structure and the support to stand up. That's one function. But you also have your spinal canal, where your spinal cord is going from your brain all the way down to the lower lumbar region, and you have posterior aspect to the spine, and that provides protection. You know, it's very hard, bony protection from any kind of injury hitting your back and injuring the spinal cord. So when there's fractures, it depends on the type of fracture. Now, a lot of fractures in the back are related to trauma.
Right.
Okay, so if you have those types of trauma, it depends on what's fractured. And the fractures can happen right through the vertebral body or in the spinous processes or the posterior part, and that becomes more dangerous because those fragments can then impinge upon the cord and cause some very serious and sometimes permanent damage.
Okay.
And those fragments have to be gotten out of or supported. Fractures through the vertebral bodies will also sometimes need to get fixed with implementation, where they go in and they use screws and plates and rods to permanently help support that. But with a compression fracture, that's different. That's strictly related to the brick part. And what happens is it's compressed. And it's a straight down load
So it's
onto
not,
the vertebral body.
it's not cracked, it's
crushed.
Okay.
Kind of think of it as a crush injury.
Okay.
And it's usually, it can happen with trauma, generally ejection from out of a seat, so falling off of a chair, landing on your bottom, falling off bikes, being ejected from a vehicle, can cause these types of injuries. But there's a variety of things that could be the root of a compression fracture. Trauma is definitely a significant one. Osteoporosis is a very significant one, and that's where we see most of our patients coming from, at least as far as the compression fractures. And then there's also infection and tumor.
okay. So in that compression fracture, it gets, everything just kind of smushed, and your discs get smashed as well in between, is that?
The discs are a little more springy. They have a
Okay.
little more bounce in their step. So they can usually bounce back. So yes, they get compressed, and you can actually squish one of them, so where you just have bone on bone, but that's a different type of problem. Usually with these, we see them in a lot of the osteoporotic patients. So it's slowly over time, it'll get a little smaller, and then usually it'll get what we call anterior wedging. So the front part gets triangular. So it just gets, and then what happens if they get multiple levels, the patients will become
Starts to
more
hunch
and more what we call kyphotic. They start hunching over, and most of the fractures are happening in the thoracic and their lumbar vertebrae, so they start doing this, and you'll see it. They'll lose very significant height of their body because they've been losing the height of their vertebral bodies.
Okay. So if you have a compression fracture, are you going to know it right away? What are the symptoms?
Symptoms are pain. Always pain. You won't always get pain with your fracture, but if you're going to have a symptom, it's going to be pain, and you'll usually know it right when it happens.
Okay, so a lot of people suffer from back pain. Oh, I was out gardening, or I moved my neighbor and my back hurts. That doesn't mean, what kind of pain, you know, how can you describe the pain of a compression fracture?
Generally, the pain of a compression fracture, it's very intense. It's usually not well controlled with just your normal NSAIDs and anti-inflammatory medication. And generally speaking, it will give you a little bit of a radiation of pain, kind of this way. Because as it goes on, it will just cause irritation to some of the intercostal nerves. And those are the ones that are associated with your ribs. So it will usually radiate in this fashion.
Okay.
And it's usually muscular pain. It usually doesn't matter what you do. The only time the pain will stop is if you're completely still.
Which is hard to
Which is hard to do.
still.
It's hard, and you can usually associate it with a traumatic event. Most people can. Now, although I will say, unusually enough, about 30% of the patients we see with osteoporosis in the elderly, it happens when they're in bed.
Really?
Twisting, turning, tossing, have a bad, crazy nightmare or something like that, or they just kind of get tied up with their pajamas. About 30% of them happen when they're in bed, or they just sit up the wrong way after many, many years of not doing much in exercise and not doing much in weight bearing and starting to get osteoporosis. The bones get weak. And when that happens, it's much, much easier to get a fracture.
Can you have a compression fracture and could it mask itself as something else? Like maybe I have a herniated disc? or is it just completely different, the pain and the symptoms?
The pain and symptoms, they can overlap. There's definitely a lot of overlap. And whenever you have issues with a disc or some type of pain, if you have pain in your back, especially if it's radiating somewhere, either around this way or down the legs, it's time to get that checked.
Okay.
You don't want this to continue on, because you can end up with some type of permanent injury to the spinal canal or spinal cord because of canal compression.
Yeah, that's what I was going to ask. If they're left untreated, what are some of the things that can happen later on?
Generally, what you're looking at is whether or not it's going to be permanent nerve injury to the spinal cord or to one of the nerves that are exiting the spinal canal.
Okay.
And it could be permanent right away, but generally what we see, I mean, especially in compression fractures, doesn't involve that at all. Compression fracture is usually localized pain from the fracture itself that's persistent over time. But to get it evaluated, the reason why is because of these other sequelae of nerve injuries.
Okay, so what are the ways that someone comes in and they, think, oh, I have a compression fracture? What are the ways that you test to see what it is? Is it an MRI, a CAT scan, an X-ray?
It depends on the patient.
Okay.
But first and foremost, it's a physical exam. Find out if there's numbness and tingling. Find out if there's weakness, asymmetry, problems. I mean, the body is very, very symmetric. And even if you're right-handed and you're a little bit stronger over here, you should have the same strength in both hands. You should have the same strength in both legs. And if I ask you to point your toes straight up or to push them down like it's a gas pedal, it should be very, very similar. So we run the patients through a series of exams. We run them through a series of physical tests to see what the problems are. Sometimes they've already had simple imaging, and the simple imaging is just X-rays. We'll get an X-ray of this through the frontal and then on the sides, and we'll see if we see any of that anterior wedging. We'll see if we've significant loss of height of vertebral bodies. And then we'll compare that to the physical exam, and we'll see if it correlates with where they're having pain. If they're having pain up high near the neck, but we don't see any compression fractures, or if we do, the compression fractures are down here and they don't correlate, well, we know it's something else.
Okay.
And then maybe they're having some type of neuralgia, and that maybe they need to see a neurologist or someone at a pain center.
Okay.
So,
do the compression fractures happen more commonly in the lower vertebrae or in the upper, up by the neck?
generally what we see them is in the lower thoracic and in
Okay.
the lumbar. Those are the ones that are keeping most of the load.
I was going to say that's probably the load is probably a lot more the lower in the spine.
Absolutely,
Okay.
absolutely. And that's where you also get a lot more of the twisting. So up here, the rib cage and the way your body's built, you don't do a lot of twisting, but you'll get more stress kind of where the chest and the abdomen meet.
Okay. So patient it's determined they have a compression fracture. Do you always have to do some sort of procedure to help, or can it get better on its own?
Absolutely, that
Okay.
can get better on its own.
Okay.
And those are the patients that we want to capture more patients that are having the pain, so we can figure out what they need to do, because probably it's about a third of maybe all patients that have this, they're only treated acutely or they're incompletely treated. What ends up happening is, especially with the elderly, they kind of get to this point where they say, well, I'm old, I'm supposed to hurt in the back. And they kind of just get into that mentality, oh, it's just one of those things about being old. Well, no, not necessarily. And sometimes maybe it is. Maybe it's some other musculoskeletal issue that's going on, but they need to be evaluated. And the one thing is, if we can help them, it would be really nice to get them where they're pain-free.
Yeah. So what kind of treatment options are available? I read something about you can inject a cement-like substance.
That's vertebroplasty,
Okay,
and
let's
that
talk-
is what we do. In the appropriate patients, sometimes if it's nerve root injuries, maybe all they need is a facet injection or something like that. But where we come in is offering vertebroplasty or kyphoplasty. And
Okay.
there's a subtle difference between the two, but they're both performed in a very, very similar way. If the pain correlates with what they're having, where the compression fracture is, if it's a fracture that's been going on at least 4 weeks minimum, where it's poorly controlled, even with narcotics sometimes, and back brace or anything like this, and generally we like them to be around the 8 to 10 week range, so we know that they've had a really good time for either healing to have occurred or for them to find a pain regimen that works. And if not, well, then we can usually offer some very, very significant relief, and it's almost always immediate.
Okay.
The procedure is vertebroplasty, and then what we do is we'll bring them in to the interventional suite, and generally we'll have them laying in a prone position where they're face down, and we use, again, the fluoroscopy to find out and correlate, make sure we're at the right level. Wouldn't do good to get the wrong level.
That's right.
We get them in a sterile condition, and then we access and we make really small incisions. Now, depending on who's doing it and the type of fracture and a couple of other things, to whether or not they get one incision or two. And then what we do is we have these, what we call trocars, and we advance them from the skin and through certain specific ways into the vertebral body, and we check both in the AP, or in front to back, and in the lateral, because we actually have x-rays going on both sides, and we check our position in 3D, and then once our needles are in the appropriate place, we add the cement.
Okay.
And the cement is actually mixed with like a barium compound, so we can see that as we inject it.
Okay.
Absolutely. And then what we do is we inject a little bit, and then we look. We inject a little bit, and then we look. And what we look for is proper distribution and placement of the cement. We make sure that our needles are in a certain position, and there's a very, very precise way to do it. But once the cement starts traveling, it interdigitates to the fracture fragments and solidifies, and it stops them from grinding on each other.
Okay, so it kind of fills up that space and
Kind of
sort of
fills up
opens
that
it back
space.
up. Okay.
It doesn't, the vertebroplasty itself doesn't actually regain a lot of height, although I've seen it regain a little bit of height. But there's the other partner to this is kyphoplasty.
Okay.
And with kyphoplasty, once you have access with your needles, then you insert a balloon. The balloon kind of pushes the vertebral body back to a more normal state, and then it's that cavity, you remove the balloon, and then it's that cavity you fill with cement. And that will actually gain you some height, which is important because some people, if they've had multiple vertebral fractures and they start becoming very, very kyphotic, they can start getting some very serious respiratory issues, and they can't breathe as well, and they're more prone to infections and some other issues. So kyphoplasty actually has a role in really regaining height in some of these people.
So what's the recovery time for if someone has that?
There's almost none.
Really?
They come in as an outpatient, whether or not we use full anesthesia or we use just kind of really monitored heavy sedation. We do our procedure. They get monitored for about an hour to 3 hours afterwards. Then they go home.
Really? That's amazing.
We can do multiple levels at one time, although most of us have kind of about a 3-level mark where we usually won't do more than 3 levels at a time because just the risks start going up for the patient. And the pain relief is almost immediate. As soon as they start sitting up, most of the patients I've seen have near complete resolution of their pain.
So those are the most common procedures. That's what you perform. Are there other things that can be done, or is this kind of the standard of what's being done?
This is kind of the standard for compression fractures. Now, some people, even if they have a compression fracture, won't be candidates.
Okay, who's not a candidate? Let me ask
Well,
you that.
if they've had complete loss of vertebral body height, if we actually can't get in there with our needles and we don't think that there's going to be any success in actually solidifying what's literally kind of like a pancake, or what they call vertebra plana. It is so small and so flat, there's almost no vertebral body left. If a patient has one of those, it's really hard to justify going in there. Although if they also have significant pain, it's kind of hard not to say, well, we could try. But for mostly, if they've had one of those, or if it's very, very chronic, if it's been going on for so long that we don't think that we're going to be successful, that's something else that would limit us. But generally speaking, the biggest thing that we have to look for is even if it's a compression fracture, it can have fracture fragments. and sometimes, or displacement. And if the vertebral body or fracture fragments are displacing backwards and they actually start getting very close to the cord or causing compression of the cord, that's something we wouldn't do. And more than likely, they're going to need full neurosurgery. And they'll have to get a neurosurgery consult where they may have to go in there and do plates and other types of fixation so that they can relieve the compression of the cord.
Do you find those more severe cases are in your older patients who maybe have osteoporosis or something like that versus someone that maybe got a compression fracture who's a little younger from a traumatic injury or event?
Yeah, it depends on the type of injury.
Okay.
And I would say that most of our patients are the elderly. We get a few people that are young and they have focal from trauma, but no, most of our patients are still elderly, so it really does depend on the person and the type of injury.
Okay. So from what I gather, if you have been it's best to get this treated and not wait.
You don't
well,
want to wait
no
too
one
long.
No one wants to live with that kind of pain, but you do recommend that there's some, you go through other courses of treatment.
Absolutely. I don't think that we would be doing them justice if we didn't give them an opportunity, at least 2 to 4 weeks to heal. In fact, I think I want to say that's the Medicare or Medicaid standard, is 2 to 4 weeks of conservative management, medications, back brace, bed rest. But at the same time, it gets to a point where if you have bed rest and a back brace and you're not lifting any weights whatsoever, well, that makes osteoporosis worse.
Oh,
and
yeah,
then they're going to end up kind of, you get to be this cat chasing its tail. And it's like, well, we want to help this patient and we don't want things to get worse. But at the same time, we want to give them that opportunity so they don't have to go through the procedure. So sometimes it's a fine line. But weight-bearing exercise and just getting and being active is going to forestall osteoporosis. So we definitely want to get these patients back to doing what they do because it limits the lifestyle.
But is the weight-bearing activity, are there activities that you should avoid if you're sort of in that phase where you have a compression fracture and you're kind of in that phase of trying to heal, things that you shouldn't be doing?
You definitely don't want to be doing the activity that caused it.
Okay.
Unless it was rolling over in bed, in which case that's kind of hard to avoid. If it was weight-bearing exercise, you want to avoid that. If it was trauma, you want to avoid that. Sometimes it's home issues. Sometimes it's a patient that needs a walker, but they just can't get to the place where I'm not old enough to need a walker. Well, if you need a walker, you need a walker. And the most important thing is to make sure that you're still going to be able to have the independence, because this type of injury, this type of trauma is very significant. It really increases mortality in the elderly by about 15%. It increases depression. It decreases independence, and you'll have people that are living alone, doing a good life, active, doing whatever they want. They get a vertebral compression fraction, and then all of a sudden their life has been severely restrictive, and this is a procedure that can really get them back to doing what they want to do. So sometimes home evaluations, making sure, do you have rugs that are going to trip you?
Right.
That's very important. To sometimes have a home inspection to make sure that your home is safe. Handrails or seats in the tub so you don't slip and fall. Make sure you don't have any loose rugs, walkers if you need them. Do you need to make sure that you have a different access to the front door or the back door? Do you need a ramp? Do you need more steps? Are your steps too high? Or you have wobbly steps? All of these things need to be looked at because you want to have a safe home environment. Because if you fall, that can be very, very dangerous for people with osteoporosis, or even people, that are elderly that are living alone.
Okay, well, Dr. Babcock, thank you so much for coming on the show again and giving us good information. I didn't know anything about this, and it sounds like there's treatment options out there that can help people, get back to the life that they want to live without pain.
Yep.
Thank you.
You're welcome.